Hey everyone, welcome back for another deep dive. Today we're going to be tackling bacterial meningitis.
A classic, but always relevant, right?
Absolutely, especially with the WHO's AWARE guidelines, access, watch, and reserve always being updated. We're going to be focusing on the bacterial meningitis chapter specifically, pulling out those key takeaways for our fellow microbiologists out there.
Sounds good.
Yeah.
Even for those of us who've been in the field a while, there's always something new to learn from these guidelines.
Okay, so let's start with the basics. What exactly is meningitis? I mean, we all know it's, an inflammation of the meninges.
Right, yeah. Basically, meningitis is when those membranes surrounding the brain and the spinal cord get inflamed. And of course, there are different causes, viral, fungal. But today, we're zeroing in on the bacterial kind. And even though the definition might seem pretty straightforward, diagnosing and treating bacterial meningitis is a whole other story.
For sure. Clinically, it can be a real puzzle sometimes. We all learned that classic triad of symptoms: fever, headache, and neck stiffness.
Right, the classic triad. The problem is it's not always so clear-cut in real life. Studies show that only about half of patients actually present with all three.
Is that right? Only half?
Yeah. And get this, the WHO guidelines actually point out that up to 5% of patients, they might not even have two of those classic symptoms.
Wow, so we can't just rely on that triad.
Nope, you got to be super vigilant, especially when you're dealing with those more atypical presentations.
Okay, so let's say we have a patient, and we really suspect bacterial meningitis.
Yeah.
What are the top lab tests that we should be running?
Well, first and foremost, you got to get that cerebrospinal fluid, right? A lumbar puncture for CSF analysis is absolutely critical. And the AWARE guidelines, they really emphasize this. Get that sample before starting antibiotics.
Time is brain, right.
Exactly.
But okay, for those of us who haven't looked at CSF in a while, what exactly are we looking for in that analysis?
All right, so you're looking for a few key things. First, you'll see elevated opening pressure. The fluid will look cloudy, turbid. Then you'll see a high white blood cell count, and mostly neutrophils. And you'll also notice elevated protein levels and low glucose, especially when you compare it to the serum glucose. That low CSF to serum glucose ratio is a strong indicator that you're dealing with some bacterial activity.
So we're putting all these pieces together like a puzzle.
That's a great way to put it. And of course, we can't forget about our friends in the microbiology lab. They're the ones who help us pinpoint the exact bacterial species causing the infection. So CSF microscopy and culture, those are essential.
Makes sense. And those cultures, they'll give us the antibiotic susceptibility.
Exactly, yeah. So speaking of antibiotics, I'm curious how do the AWARE guidelines approach antibiotic selection? Because, it's always changing, isn't it?
Yeah, antibiotic resistance is a huge problem. It feels like we're constantly playing catch up.
It's true. And that's why these guidelines are so important. They give us a solid framework, taking into account local resistance patterns and even drug availability. But before we get into the specifics of the antibiotic regimens, let's finish up talking about those other lab tests.
Right. There's more to the story than just CSF.
Absolutely. We need to look at the patient's overall health, too. A complete blood count can tell us a lot. Elevated white blood cells that can support our suspicion of infection. And comparing blood glucose to CSF glucose, that's essential for getting that diagnostic ratio we talk about.
CBC, blood glucose, got it. Anything else?
Yeah. Inflammatory markers like CRP and procalcitonin can also be really helpful. They can tell us how severe the inflammation is and help us monitor how the patient's responding to treatment.
Right. Makes sense. What about blood lactate? I always forget about that one.
Oh, blood lactate. Yeah, that's a good one. It can be a really sensitive marker of tissue perfusion. And it can also alert us to potential sepsis, which, can be a complication of severe meningitis.
Okay, so we've got a pretty comprehensive picture with all those tests. But what about imaging? When does a head CT scan come into play?
So CT scans, those are really useful in specific situations, especially before we do a lumbar puncture. Like if the patient is showing any focal neurological signs, or maybe they have a decreased level of consciousness, or even a history of CNS disease. In those cases, we want to rule out any other problems, like structural abnormalities or increased intracranial pressure, because those things could make a lumbar puncture risky.
So it's all about weighing the risks and benefits for each individual patient.
Exactly. But here's the key takeaway. Even if a CT scan is necessary, we should never delay starting those antibiotics if we suspect bacterial meningitis. Every minute counts.
I completely agree. Okay, let's talk about the elephant in the room, antibiotics. What are the WHO's recommendations based on their AWARE classification?
So The AWARE approach, it categorizes antibiotics based on their availability, safety, and efficacy. It's really practical. For empiric therapy, we want to cover the most likely pathogens while we're waiting for those culture results,
Really,
right?
could cover all our bases.
Exactly. So in both adults and children, the guidelines recommend starting with either ceftriaxone or cefotaxime. Those are our first-line access antibiotics, those third-generation cephalosporins.
Okay, those are the big guns.
Yeah, and they work really well in most cases, but local availability and resistance patterns might mean we have to choose one over the other. It depends.
It always depends. Okay, what about those situations where ceftriaxone or cefotaxime aren't an option?
Well, in those cases, we'd move on to our watch category.
A backup plan.
Right, exactly. So for adults, that would include options like amoxicillin, ampicillin, or benzylpenicillin. And of course, the AWARE guidelines, they have specific dosage recommendations for all of those alternatives.
That makes sense. Now, I remember the guidelines really emphasized considering Listeria monocytogenes in certain patient groups. When should we be extra cautious about that one?
Oh, you're right. Listeria. It can be tricky, especially in older adults, pregnant women, and anyone who's immunocompromised. We have to be really careful with those groups. And we'd add ampicillin to the empiric regimen to make sure we're covering Listeria.
So even if we're using a watch antibiotic, we might still need ampicillin.
Yep. Sometimes it's all about making sure we're covering all the possible culprits.
Got it. Okay, what about those reserve antibiotics like chloramphenicol? When do those come into play?
So reserve antibiotics, those are our last resort. We only use them when the first-line and second-line options are either unavailable or just not effective. Chloramphenicol in particular, it has some potential toxicity issues, so we try to avoid it if we can. But the AWARE guidelines do have guidance on dosage and administration for it, just in case.
Always good to have a backup for the backup plan.
Exactly. Now, before we move on to the treatment specifics, let's take a step back and delve into the pathophysiology of bacterial meningitis a bit. Understanding how these pathogens work, it helps us appreciate why prompt treatment is so crucial.
That's a great point. Sometimes we get caught up in the details and forget to see the bigger picture.
It happens to the best of us. So let's think about it this way. These bacteria, they often hang out in the upper respiratory tract, and then they invade the bloodstream, causing bacteremia. And eventually, they reach that blood-brain barrier.
And from there, they get into the CNS.
Right. And unfortunately, the central nervous system, it doesn't have the strongest immune defenses. So these bacteria, they get in and they can multiply really quickly.
And that causes all those classic symptoms we talked about.
Yeah. The fever, the headache, the stiff neck, it's all because of that inflammatory response triggered by the bacteria. And in severe cases, you can even get brain swelling, seizures, and even permanent neurological damage.
So it's not just the bacteria themselves, it's our own body's response to them that can cause the real damage.
Exactly. Which is why, again, prompt treatment is so important.
Okay, let's shift gears a bit and talk about the epidemiology of bacterial meningitis. What are some key things our listeners should know about the global impact of this disease?
So meningitis, it's a worldwide problem. It affects people of all ages, but it hits children under 5 the hardest. We've made some good progress with vaccinations, especially for Haemophilus influenza type B. But bacterial meningitis is still a huge burden, especially in those low and middle income countries.
I remember learning about the meningitis belt in sub-Saharan Africa. It's a really stark reminder of how unequal access to healthcare is around the world.
That's a good point. The meningitis belt, it covers a large part of Africa, and they have a particularly high incidence of meningococcal meningitis outbreaks, especially during the dry season. And there are a lot of factors that contribute to that, like overcrowding, dust storms, and even just upper respiratory tract infections, which can make people more susceptible.
It's a complex problem for sure.
Definitely. But the WHO, they've been doing a lot to combat meningitis in those areas, with vaccination campaigns and surveillance programs. Their goal is to defeat meningitis by 2030, which is ambitious, but it's crucial.
Definitely. We've got to aim high. Okay, now for the fun part. Let's talk about those bacterial bad guys, the most common culprits.
Right, the usual suspects. So in children and adults, the top 3 are Streptococcus pneumonia, Neisseria meningitis, and Haemophilus influenza. And like we talked about before, we got to keep Listeria monocytogenes in mind, especially for those older adults, pregnant women, and immunocompromised folks.
Right, those are the big ones. Are there any other pathogens that we should be aware of?
Oh yeah, definitely. In places where tuberculosis is common, or in patients with HIV, Mycobacterium tuberculosis needs to be on our radar. And for anyone who's severely immunocompromised, we can't rule out fungal causes like Cryptococcus.
So much to consider.
It's true. And let's not forget about healthcare-associated meningitis, especially in patients who've had neurosurgical procedures. In those cases, Staphylococcus aureus and gram-negative bacteria, especially the ones that are resistant to multiple antibiotics, those become more likely.
Healthcare settings can be breeding grounds for those resistant strains.
It's true. Okay, so are you ready for a little quiz? Let's put your knowledge to the test.
Oh, I love a good quiz. Hit me.
All right, question number 1. What is the classic triad of symptoms associated with meningitis, and why can't we rely on it completely for diagnosis?
Okay, so the classic triad is fever, headache, and neck stiffness. But we can't rely on it completely because, well, not everyone presents with all 3 symptoms. And in fact, some patients might not even have 2 out of the 3.
You got it. It's tricky, right?
Okay, what's next?
All right, here's the scenario for you. You have a 72-year-old patient with suspected bacterial meningitis. What additional antibiotics should you include in their treatment, and why?
Well, because of their age, we have to be thinking about Listeria monocytogenes. So in addition to a third-generation cephalosporin like ceftriaxone or cefotaxime, we'd want to add ampicillin to cover that potential pathogen.
Bingo. All right, question number 3. A CSF sample from a patient with suspected meningitis shows elevated opening pressure, cloudy appearance, high white blood cell count with mostly neutrophils, elevated protein, and low glucose. Based on these findings, is this more likely bacterial or viral meningitis?
That sounds like bacterial meningitis to me. All those signs point in that direction.
You're on a roll. Okay, next question. What are the 3 main bacterial pathogens that the AWARE guidelines recommend covering empirically in both children and adults with suspected meningitis?
Okay, let me see. We've got Streptococcus pneumonia, Neisseria meningitis, and Haemophilus influenza.
Nailed it. All right, last one. A patient comes in with suspected meningitis after a recent neurosurgical procedure. What bacteria should we be most concerned about in this case?
Ah, so this is a healthcare-associated meningitis situation. We need to be thinking about Staphylococcus aureus and gram-negative bacteria, especially the ones that are resistant to multiple antibiotics.
You aced it. You're a bacterial meningitis expert now.
Well, I wouldn't say expert, but I definitely feel more confident after this review. Thanks for the quiz.
My pleasure. So are you ready to dive into those antibiotic regimens?
Absolutely. Let's get into the specifics.
Okay, so we've touched on those aware, access, watch, and reserve categories. But let's get into the nitty-gritty of the actual dosages, those recommendations, because those are important.
Absolutely. Those details matter.
Yeah.
So let's start with the access antibiotics. Ceftriaxone and cefotaxime. What are the recommended dosages for those?
All right, so for adults, ceftriaxone is typically giving us 2 grams intravenously every 12 hours.
And what about cefotaxime?
Cefotaxime, that's usually 2 grams intravenously, but every 6 hours for adults.
Okay, so slightly different schedules there.
Yeah.
Now, what about the duration of treatment? Is it the same for every type of bacterial meningitis?
Well, no, it actually varies. It depends on a few things, like which bacteria is causing the infection and how well the patient is responding to treatment.
So it's not a one-size-fits-all situation.
Right. For example, if it's confirmed pneumococcal meningitis, we'd usually treat for 10 to 14 days. But for meningococcal meningitis, a shorter course, maybe 5 to 7 days, might be enough.
Okay, so it's important to individualize the treatment plan.
Exactly. Now let's move on to those watch antibiotics, the alternatives when ceftriaxone or cefotaxime aren't suitable.
Right, like amoxicillin, ampicillin, and benzylpenicillin. What are the dosages for those?
Okay, so for amoxicillin in adults, it's usually 2 grams intravenously every 4 hours.
And any ampicillin?
Ampicillin is the same, 2 grams intravenously every 4 hours for adults.
Got it. And benzylpenicillin?
Ah, yes, benzylpenicillin. That one's a bit different. It's 3 million units intravenously every 4 hours for adults.
Okay, good to know. So we've got those access and watch antibiotics covered. Now, what about the reserve category? Specifically, chloramphenicol.
Right, chloramphenicol, that's our last resort. We only use it when those first-line and second-line options aren't available or if they're just not working. And we have to be really careful with it because it can be toxic.
So it's like breaking the glass in case of emergency.
Yeah, that's a good way to put it. And if we do have to use it, the dosage for adults is 25 milligrams per kilogram of body weight, given intravenously every 6 hours. But again, we try to avoid it if we can.
Right, because of those potential side effects. Now, I know we've talked about dosages, but I'm wondering, are there any situations where we might need to adjust those dosages?
Oh, absolutely. You're thinking about renal function, right?
Exactly. What do we do if a patient has kidney problems?
Well, in those cases, we definitely need to adjust the dosage to avoid those drugs building up in the body. The AWARE guidelines actually have specific recommendations for dosage adjustments based on creatinine clearance levels. So it's really important to check those guidelines, make sure we're being safe and effective.
Always check those guidelines. That's
Yeah.
good advice. Okay, so we've covered a lot of ground with the antibiotics, but now I think it's important to step back and talk about the big picture. How does a bacterial meningitis actually work? What's going on in the body that causes all these symptoms and makes this such a serious infection?
That's a great point. Sometimes we get so caught up in the details that we forget to look at the whole picture. So let's break down the pathophysiology of bacterial meningitis.
All right, let's do it.
So first, you've got these bacteria, right? And often they start by colonizing the upper respiratory tract. From there, they can invade the bloodstream.
Causing bacteremia,
Exactly. And eventually, those bacteria reach that blood-brain barrier.
which protects the central nervous system.
Right. But unfortunately, that blood-brain barrier, it's not foolproof. And the central nervous system, it doesn't have the strongest immune defenses. So it can be vulnerable to attack.
So those bacteria can get through and start causing problems.
Exactly. And once they get into the CNS, they can multiply really quickly, and that triggers that inflammatory response that causes all the symptoms we've been talking about.
The fever, the headache, the stiff neck.
Exactly. And in some cases, that inflammation can lead to even more serious problems like brain swelling, seizures, and even permanent brain damage.
So it's not just the bacteria themselves that are dangerous, it's our own body's response to them that can cause the real harm.
Exactly. And that's why prompt treatment is so important. We need to stop that inflammatory cascade before it causes irreversible damage.
It's all about timing. Okay, let's shift gears a bit and talk about the global impact of bacterial meningitis. What are some key epidemiological points that we should be aware of?
Well, meningitis, it's a global problem affecting people of all ages, but it really hits children under 5 the hardest. And, we've made some good progress with vaccinations, especially for Haemophilus influenza type B, but bacterial meningitis is still a major cause of illness and death worldwide, especially in those low and middle income countries.
Right, it's a reminder that access to healthcare is a huge factor. Remember learning about the meningitis belt in sub-Saharan Africa, where meningococcal meningitis outbreaks are a serious problem. What can you tell us about that region?
The meningitis belt, it's a large region in Africa that has a particularly high incidence of meningococcal meningitis outbreaks. And it's a real challenge because there are a lot of factors that contribute to those outbreaks. Things like overcrowding, dust storms, and even upper respiratory tract infections, which can make people more susceptible.
It sounds like a perfect storm for spreading those bacteria.
It really is. And while vaccination campaigns have made a difference, there's still a lot of work to be done to control those outbreaks. The WHO, they have a goal to defeat meningitis by 2030, which is, it's ambitious, but it's absolutely crucial.
I've got to aim high. Okay, let's talk about those specific bacteria that cause meningitis. We've mentioned a few already, but I'd love to get a more comprehensive overview.
Sure. So in both children and adults, the most common culprits are Streptococcus pneumonia, Neisseria meningitis, and Haemophilus influenza.
Right, those are the big three.
Yep. And we always have to keep Listeria monocytogenes in mind, especially for those older adults, pregnant women, and anyone who's immunocompromised.
Right, those are the high-risk groups.
Yeah.
Are there any other pathogens that we should be considering?
Oh, definitely. In areas where tuberculosis is common, or in patients with HIV, we need to think about Mycobacterium tuberculosis. And in folks who are severely immunocompromised, fungal causes like Cryptococcus, those can also be a problem.
So much to consider.
It's true. And we can't forget about those healthcare-associated infections. Those cases where someone develops meningitis after a neurosurgical procedure. In those cases, Staphylococcus aureus and gram-negative bacteria, especially the multi-drug-resistant ones, those are more likely.
It's a reminder that those hospital settings can be a real breeding ground for those resistant strains.
That's true. Okay, are you up for another quiz? Let's test your bacterial meningitis knowledge.
All right, hit me with those questions.
Okay, question number 1. What is the classic triad of symptoms associated with meningitis, and why is it so tricky to rely on that triad alone for diagnosis?
Okay, the classic triad is fever, headache, and neck stiffness. But it's tricky to rely on that alone because not every patient presents with all three symptoms. Some people might only have one or two, and some might not even have any of those classic symptoms.
Sorry, it's not always clear-cut. All right, question number 2. You have a 68-year-old patient with suspected bacterial meningitis. What additional antibiotics should you consider adding to their treatment regimen, and why?
Okay, so with an older patient, we have to be thinking about Listeria monocytogenes. So I would add ampicillin to their regimen to cover that possibility.
You got it. Older adults are definitely at higher risk for Listeria meningitis. All right, question number 3. You get a CSF sample from a patient with suspected meningitis, and the lab report shows elevated opening pressure, cloudy appearance, high white blood cell count with mostly neutrophils, elevated protein, and low glucose. Does that sound more like bacterial or viral meningitis?
Those findings are screaming bacterial meningitis. That
Yeah.
combination of results is very classic.
You're on a roll. Okay, question number 4. What are the 3 major bacterial pathogens that the AWARE guidelines recommend covering empirically in both children and adults with suspected meningitis?
Let's see, we've got Streptococcus pneumonia, Neisseria meningitis, and Haemophilus influenza.
Perfect. Those are the big 3. Okay, last question. A patient comes in with suspected meningitis after having a neurosurgical procedure. What bacteria should be at the top of your differential diagnosis list in this case?
Okay, so after a neurosurgical procedure, we're thinking about healthcare-associated meningitis. So the most likely culprits would be Staphylococcus aureus and gram-negative bacteria, especially those that are resistant to multiple antibiotics.
You aced it again. You're a bacterial meningitis whiz.
Well, I don't know about that, but I feel much more confident about my knowledge after this review. Thanks for the quiz. It's always a good way to solidify those concepts.
Absolutely. So are you ready to wrap up this deep dive with some final thoughts?
Let's do it. I always love hearing your insights. It's amazing how much there is to know about bacterial meningitis. We've covered everything from those basic definitions to the global epidemiology and all those specific antibiotic regimens.
It's a complex topic for sure, and the AWARE guidelines, they do a great job of, providing that framework for us.
Speaking of those guidelines, one thing I was wondering about is those dosage adjustments, for patients with kidney problems.
Yeah, renal impairment, that's a really important consideration.
So how do we adjust the dosages for those patients? Do the AWARE guidelines address that?
They do. They actually have very specific recommendations for dosage adjustments based on creatinine clearance. So it's really important to consult those guidelines whenever you're treating a patient with renal impairment, to make sure you're not overdosing them.
Right. Safety first. It's a good reminder that even with these guidelines, we still need to think critically and individualize those treatment plans.
Absolutely. No 2 patients are exactly alike.
Well, this has been a fantastic deep dive. I always learn so much from these conversations.
It's been my pleasure.
And to all our listeners out there, thanks for joining us for another deep dive. We hope you found this episode informative and maybe even a little bit entertaining. Stay curious, keep learning, and we'll see you next time.